We're going to start out looking at heart defects that cause an increase in pulmonary blood flow. And the first one we're going to look at is our atrial septal defect. This is an abnormal opening between the right and the left atria. Because the pressure is higher on the left side after birth, we're going to have blood go from that high pressure on the left side over to the low pressure on the right. This is well tolerated. In fact, I've known people who had one and didn't know they had one, and usually it's women during pregnancy with that increased blood volume. Suddenly they'll start being symptomatic and they'll say, "Did you know you have an ASD, a small ASD?" So this is one that sometimes goes undiagnosed for years or decades. If it is significant, it can develop some congestive heart failure symptoms. And if you think about that, we're adding more fluid to that right side of the heart that's going to send it out to the lungs, and then we add in more, and then we add in more. So we're going to see pulmonary symptoms, kind of fluid overload in the lungs. Surgically, they'll go in and put a patch, a Dacron patch there, and prognosis less than or about 1% mortality. So this is a surgery that people do very well. Ventricular septal defect. This is the one that is our most common. This is an opening between the ventricles. If it's small, it may close spontaneously by a year. So if a child's not symptomatic, they may wait to see how they're going to do. Again, we'll have left to right shunting because after birth that pressure is going to get higher in the left side. So you can see the circled area there. The blood that's already been oxygenated, instead of going to the body, is going to go back and go through the lungs a second time. It doesn't pick up any more oxygen. And if you do have symptoms, you're going to have CHF symptoms of that overload in the pulmonary system. So you'll see increased pulmonary vascular resistance. I'm not following the right order of my little bullets there, sorry. The surgical treatment, sometimes they can do just suture it together, a purse string or knitted kind of approach, or if it's large or there's multiple ones, they're going to need to put in a patch, a Dacron patch. Mortality is about 2%, but if there are more than one hole, multiple defects, your mortality is going to be higher. The next one that's causing too much pulmonary flow is an AV canal. And in an AV canal, you've basically got communication between all four chambers of the heart. All of the valves lay at the same level because your atria contract from top down and your ventricles contract from bottom up. So the valve between the atria and the ventricles is at the bottom of the atria. The valves between the ventricles and either the pulmonary artery or the aortic arch are at the top of the ventricles. So they're all on the same plane, all four valves. So what that plane there is what doesn't develop correctly. This is very common in Down syndrome, in our trisomy 21s. 1 in 9 kids with Down syndrome will have this defect. Because we have higher pressure on the left side, we're going to get more shunting from the left to the right. So we're going to take that already oxygenated blood, send it back through the lungs again. So we've got too much blood flow in the lungs, and those are the symptoms we're going to see. Palliative treatment is they'll go in and they'll put a band around the pulmonary artery. So we're making it hard for blood to go up the pulmonary artery, so less will. So we don't get this overflow of too much blood going because we've made it require more pressure to get up there. That is not a final repair though. They're going to have to go back in, create the septums dividing the chambers, and possibly create valves. Now how well these kids do really depends on how much of the valves did or didn't develop. So overall mortality rate is less than 5%. And here's a picture you can see where there's just a lot of communication between all those chambers. And a patent ductus arteriosus, remember this should be open in the fetus, and in the fetus pressure on the right is higher, so blood's going to come up from the right ventricle and cross from the high pressure of the right side to the low pressure of the left side, the aortic arch coming out from the left side of the heart. After birth, when those pressures drop on the right side, our left side becomes higher, and so it switches where our oxygenated blood comes down here and then gets sent back to the lungs for a second trip, where it really doesn't do anything except add extra volume into the pulmonary system. So it's left to right shunt. There is a potential for hypertrophy, particularly right ventricular hypertrophy, because we're having to do all this extra pumping on the right side. The medical management will use indomethacin, that's what we used to use, or ibuprofen, and I believe the specific ibuprofen is Pediatric. They'll use that to try and close it. That's a prostaglandin inhibitor. So you'll see later some of the defects where we want to keep this open, we're going to give prostaglandin. To close it, we give a prostaglandin inhibitor. If in 3 doses it doesn't close, then they'll go in and surgically close it. They can, usually what they'll do is clip it, go in and put something around that to hold it shut. They can cauterize it or do different ways of sealing it off. Prognosis is less than 1%. This is actually a closed heart surgery, not open. They have to open up the thoracic cavity to get to it, but there's no opening up of the heart itself. And now let's look at our obstructive defects, which is a coarctation of the aorta, aortic stenosis, and pulmonic stenosis. In coarctation of the aorta, we have an area that's coarced. So you can see it in the circle. See how narrow it is? That's what a coarc is a narrowing, a narrowed area, which makes, remember we said it takes a lot more pressure to push something through a straw than through a garden hose. So what happens is the pressure going into there becomes very high because it's hard to push it through, so we get that back up into, here's our parking lot is here. Well, this is our arteries leading to the head and the upper extremities. You get past the coarc, we've gone through that straw, but now all of a sudden we go from a straw to the garden hose, so our pressure is going to drop significantly, and this leads down to the lower part of the body. So what you're going to see is very high blood pressures in the upper extremities and low blood pressure in the lower extremities. Now remember, our kidney kind of helps with maintaining blood pressure. The kidney would be below that coarc. The kidney thinks we have low blood pressure. It's going to do everything it can, retaining fluid and secreting enzymes to raise our blood pressure. The brain doesn't really need it raised though, right? So our fear is that we're going to have a ruptured aorta, an aneurysm, a stroke, something in the high pressure part there bursting, rupturing, ballooning out. And the surgical treatment is to go in and open up that narrowed area and enlarge it. They may need to use a graft, kind of slit it open, use something to graft it. Sometimes they can, with a cardiac catheterization, thread in a balloon and kind of pull it through there and enlarge it. That would be a temporary, a palliative treatment, just to get the blood pressures a little more stable, and then go in and do an actual surgical repair of that. Prognosis, mortality less than 5%. Aortic stenosis, this is down here. you can see just beyond our valve here we've got a narrowed spot because of kind of overgrowth here of tissue. So again, we're trying to push through a straw instead of a garden hose. So there's a narrowing or a stricture at or just after the aortic valve. So what we're going to have is a decreased cardiac output. That left ventricle is having to push into a straw instead of garden hose, so that's hard. It's not going to. Less is going to go through, and it's going to take higher pressure to get it through, but once you get to the other side, your straw suddenly opens up into the garden hose and your pressure will drop. So we're going to see left ventricular hypertrophy. That left side of the heart gets enlarged because it's having to pump so hard. And we're going to see pulmonary vascular congestion, because that's the parking lot that this has come from, right? It's come from our lungs into here, and it can't get through, so it backs up that afterload into the lungs. That's the parking lot for this. Surgical treatment is aortic valvotomy. So they'll go in, kind of open this up, probably have to do some repair of the valve, and probably within 10 years have to replace the valve. Again, palliatively, we can probably put a balloon in there and just enlarge stuff, but that's going to be temporary. We're not going to really be able to do that for a final permanent fix. Prognosis rate about 5% in critically ill infants. Now, pulmonary stenosis, this is similar except the opposite artery here. So this is the right side of the heart going to the lungs. We've got this valve that's there's some overgrowth, somehow it's not working right, so we've got a narrowing of sending blood out to the lungs. So the right side of the heart is going to become hypertrophied because it's got to push so hard to get blood up through there. And the same sort of thing, we're going to have to go in and do a valvotomy. We may be able to do balloon angioplasty, try and stretch it out, but that's probably not the permanent treatment. Prognosis with this is much better. Mortality rate is less than 1%. But you can see if you can't pump out here, you're going to get the backflow this way. This is what's returning from the body. So your parking lot's body, and that's where you're going to see that edema. And now we go on to the next category.